You, Marco, for introducing me. Good afternoon. So after electric impedance tomography, another bedside non-invasive tool to assess lung recruitment is, of course, lung ultrasound. We can get both qualitative and quantitative information about lung aeration by lung ultrasound, and let's start with the qualitative assessment. This is the normal ultrasound findings of the lung when the aeration is normal. Between two ribs and their shadow, you can see the intercostal space, and below a sliding pleural line, and one or more A lines that are horizontal artifacts, hyperechoic artifacts, parallel to pleural line due to reverberation. When you have a loss of aeration in the lungs, you can see for moderate to severe loss of aeration B lines that are vertical artifacts arising from the pleural line and reaching the edge of your screen. And when this loss of aeration is complete, you can see a tissue-like pattern like on the right. Of course, all the black around this deaerated lobe is pleural effusion. Typically, especially in the early phase of ARDS, you can also see coalescence of B lines, small subpleural consolidation that are small anechoic image just below the pleural line, and spared areas. That means that you can see completely normal lung regions just closed to deeply involved one. How we can use these simple ultrasound signs to help us in managing patients with ARDS. For example, we know that patients with a diffuse loss of aeration may respond to PEEP and recruitment maneuver, whereas patients with a local, focal loss of aeration are not good PEEP responder. And these two very different lung morphology can be distinguished at a glance bedside, just putting a probe on the chest of your patients. On the left of this slide, you have a focal morphology, whereas on the right, a diffuse loss of aeration. And interestingly, patients who are poor responder to PEEP and recruitment maneuver seems to be good responder to prone position. So having clear and normal aeration in the non-dependent part of the lung is a condition associated with a response, a positive response to prone positioning. And if you see a completely deaerated region of the lung, you can try to have a look within this completely deaerated lobe, for example, by switching on the color Doppler, and sometimes you can see very beautiful vessels, like in this case. I think that this is the ultrasound definition of shunt. You have a completely non-aerated lung region with a perfect perfusion. So when you see something like this, you have to react to this, maybe trying to reopen the lung or redirect this flow elsewhere. This is a very interesting observation from the group of Tuzman and Suarez-Zipman. You can see on the left of the slide that there is a little subpleural consolidation at an expiration that completely disappear at an inspiration. So maybe this is an ultrasound detected tidal recruitment. And maybe it's really so, because when this author perform a recruitment maneuver and maybe adjusted B, the subpleural consolidation disappeared both at an inspiration and at an inspiration, of course. So they decrease this peripheral tidal recruitment. Another interesting option and characteristic of lung ultrasound is that lung ultrasound provides not only static information but also dynamic information. So we have here two lungs with really different aeration, normal aeration on the left and a severe impairment of aeration on the right. But you can see the movement of the pleural line is almost the same. This is not pleural sliding. This movement is not related to respiratory movements, but is just the transmission of the heartbeat to the lung. So this is the so-called lung pulse. These two lungs have very different aeration, but no ventilation for both. And this can be useful because, you know, there is not a specific ultrasound pattern defining the overstretch, the overinflation of the lung. But sometimes we can perform a sort of test in our patients. On the left, you see this typical lung pulse. So good aeration, but no ventilation. Maybe this is an over-distended, non-dependent lung regions. We try to decrease PEEP, and you see some pleural sliding now is visible, is detectable. So by this way, if you find this increase of lung sliding by a decrease of PEEP, this may suggest that there was over-distension and you decrease over-distension by decreasing PEEP. The second part of my presentations is about the quantitative or semi-quantitative assessment of lung aeration. You know that we can track the change of lung aeration by ultrasound. Normally we use in ICU a lung ultrasound score ranging from 0 to 3. 0 when all is normal, you have the A pattern, the pleural sliding with A lines, so normal aeration, and 3 when you have a tissue-like pattern that is related to a complete loss of aeration. Usually we study 6 different areas per hemithorax, 2 anterior, the upper and the lower, 2 lateral and 2 posterior, so 12 areas for the patient, and in the end we obtain a lung ultrasound, a global lung ultrasound score ranging from 0 when the two lungs are normally aerated to 36 when the two lungs are completely deaerated. And now these pocket-size ultrasound systems are available, so you can obtain picture on your patients and review and score and save your score bedside. This lung ultrasound score was successfully applied to assess the antibiotic-induced pulmonary reaeration in patients suffering from from ventilator-associated pneumonia, and also the reaeration due to PEEP increase. Interestingly, but not surprisingly, when these authors applied the lung ultrasound scoring system to the prone positioning, they observed that the response was really different in patients with diffuse loss of aeration and focal loss of aeration. So the patient with focal loss of aeration in green, they increase aeration in the posterior regions, in the dependent regions of the lung after proning, and decrease a little bit the aeration in the anterior part of the lung. Whereas patients with non-focal or diffuse loss of aeration had no change. And this is more interesting, that the change of the lung ultrasound score was greater in patients that had a positive response to prone positioning, when the positive response was defined as a PF ratio higher than 300 after 7 days of treatment, where treatment was prone positioning for at least 6 hours twice daily. In our unit, we used to monitor VV ECMO patient with lung ultrasound. This is a small case series, and you can see this is lung ultrasound score over time, and you can see that the patients we were not able to wean from ECMO and actually died on extracorporeal support had really a different trajectory compared to the others. So, is lung ultrasound just beautiful image, or we can get from this technique a quantitative information similar to CT? We perform together with Davide Chiumello and his group a quantitative CT scan and ultrasound comparative assessment of lung aeration in ARDS, and in the end we found a quite good correlation between the global lung ultrasound score and the average lung tissue density. And if we look at the regional aeration, you can see that regions with different lung ultrasound score are also characterized by different tissue. Region with a lung ultrasound score of 0, so normal pattern, have more than 60% of normally aerated tissue as assessed by CT, and less than 10% of non-aerated tissue. On the opposite, regions with a lung ultrasound score of 3, so with lung consolidation, have more than 60% of non-aerated tissue and less than 10% of well-aerated tissue. Regions with different lung ultrasound score, of course, have different average lung tissue density, but you can see that there is some, maybe too much overlap. So we tried to improve further this scoring system, and we now suggest this modified lung ultrasound scoring system. Briefly, we suggest to use the transversal and not the longitudinal probe orientation, just to obtain a sort of full screen view of this pleural surface in order to improve our capability to see ultrasound signs, and we redefine the loss of aeration. In the original score, we give 1, so we say that is a moderate loss of aeration when we can see at least 3 B lines, irrespective of the number of B lines. And we give 2, so severe loss of aeration, when we see coalescence of B lines, irrespective of the fact that, especially in the early phase of ARDS, patient may show very small localized coalescent B lines. So we simply suggest to give 1 when less than 50% of the pleura is involved, and 2, severe loss of aeration, when more than 50% of the pleura is involved. And last point, if we define recruitment as a decrease of deaerated, non-aerated lung tissue, for sure this is not related with a change in lung ultrasound score, because lung ultrasound score is a score of aeration. Anyway, we can try to measure the derecruited lung by lung ultrasound, just measuring the area of consolidation. I don't like the technique proposed by these authors, but I like their idea, and this is my way to try to compare the amount of derecruited lung before and after a recruitment maneuver. So on the left, you can see that the dependent part of the lung is completely deaerated. We perform in this patient bronchoscopy and then a recruitment maneuver, and the effect was clearly visible bedside. So I go to my conclusion. Lung ultrasound, in my opinion, provides reliable, non-invasive, fast and repeatable, both qualitative and quantitative assessment of lung aeration, can guide some way settings of mechanical ventilation, and is for sure an ideal tool for monitoring, because it's repeatable and you don't need to move the patient. Thank you for your attention.